to our first episode where we talk about the diagnostic procedures and the occlusal relation record methods. We know that the occlusion between the mandible and the maxilla is a result of many other surrounding structures that are the temporomandibular joint, the surrounding muscles, the gingiva, and the bone surrounding the tooth. So we must do an external brief examination to those surrounding structures before we take a decision to do a prosthodontic procedure. For the temporomandibular joint, we palpate it bilaterally by putting the middle finger anteriorly to the auricular trachea while the patient opens and closes their mouth, so we can make a comparison between the timing of the left and right. If there is any disorder or pain, this indicates an inflammation that is happening in the retrodiscal tissues where they are highly vascular and innervated. As for the clicking of the temporomandibular joint, it is noticeable by placing our fingertips under the patient mandible to permit identifications of minimal click, because there is a very little soft tissue in this area. Now for the muscle palpation, we palpate several muscles: the masseter, the temporalis, the trapeze muscle, and the sternoclenoid mastoid muscle, and the floor of the mouth. Also, other muscles are the temporalis, also, this is number C, the masseter, the superficial and the deep, the neck region, the sternoclenoid mastoid muscle, this is it, number F, and the medial pterygoid G, the lateral pterygoid J, and the digastric posterior one muscle H. The palpation is done bilaterally, and the patient is asked to identify any differences between the left or the right. After we finish the external examination, we can go intraorally and take an examination photos. They are recommending that drying and polishing the mirror with sterile cotton, adding to it some alcohol, will prevent it from being fogged from the breath of the patient. Also, another trick, we can use a dishwashing solvent to reduce the fogginess on the mirror when we are going to take intraocular photographs. Now we will discuss how we are going to take the occlusal relationship between the maxilla and the mandible in the traditional way and in the modern way, using the CAD-CAM and the intraocular scanner. Let's take a brief. The concept is that we first take the relationship between the maxilla and the condylar process in the skull, using what is called the face bow. Then we transfer this relationship to an articulator, where we articulate the maxilla first, and the third step is we take the central relationship, which is the relationship between the maxilla and the mandible in a Depending on this relationship, we mount the mandible in accordance to the maxilla to take an accurate resemblance of the occlusion of the both arches. Now we will discuss these steps in more details. With the advancement of the CAD/CAM optical scanning, we were able to reassess the mandibular transverse horizontal axis, which is the axis where the mandible rotate within the sagittal plane, which is also called the condylar axis. So the CAD/CAM technology can scan the both arches in static form in the intercuspation and when the mandible is moving in real time without any interference. There is only one limitation, that the video recording is considered large in size, so only a portion of the occluding dental arches can be viewed at one time. Here we see that the scan was able to detect the movement of we can see the occlusal pathway of the canine in a working mandibular movement that can be seen from the buccal and the lingual side. However, regarding these advances, we should know and understand the concept behind the traditional articulators and how we can use them properly. Articulators can simulate the movement of the condyles in their corresponding fossa. They are classified according to how closely they can reproduce mandibular border movements. The simple non-adjustable articulator, this is it, is limited and they do not have the capacity to reproduce the full range of mandibular movement because there is a difference between this hinge and the patient. The distance between the hinge and the tooth to be restored is less on most of the non-adjustable articulators. This means that we will have a premature tooth contacts that will lead to a need for share time adjustment of the occlusion, so they are not recommended for wide restorations. As for the actual articulator that gives us a range of movements, they are divided into two main categories. The first is the Archon type and the non-Archon type. What are the difference between them? In the Archon articulator, the condylar spheres are attached to the lower component of the articulator, which is anatomically correct. These are the Archon articulators, where the angulation of the mechanical fossa of an is fixed in relation to the occlusion plane of the maxillary cast. We are allowed to do adjustment to the condylar inclination and the progression or immediate side shift of the mandible in accordance to the maxilla. The non-Archon articulator, its condylar spheres are attached to the upper component of the articulator. So the full adjustable articulator, or the Archon, is usually time-consuming and requires a high level of skill and understanding from the dentist and the technician. In the Archon articulator, the dentist can remove the maxillary and do full and complete movements, which requires high precision in maintaining the occlusal stability throughout the building of the restoration. As for the face bows, they are used to record the anterior-posterior spatial position of the maxillary surface in relation to the transverse opening and closing axis of the patient's mandible. As we said before, after we take this relationship using the face bow, the mandibular cast is related to the maxillary using the intraocclusal record, which is the central relationship. Also, the face bow has two types, the average axis and the kinematic. The average axis are less accurate than the kinematic. The average face bow is that we put the face bow inside the ear. On the contrary, for the kinematic, we attach it directly to the condyle, which gives it more precise results, but the kinematic is usually used when we have an complex fixed prosthodontic procedure where we are going to rebuild the vertical dimension. These are real pictures of the kinematic face bow. We see that the attachment is directly on the condyle. Now let's see how do we use the face bow in our daily clinic routine. There is two ways to take the relationship of the maxilla with the bone. The first one is using the modeling plastic impression compound, where the face bow fork is positioned inside the mouth and it is attached to and tightened. Then the patient occludes and we take the impressions. Here we take the measurement of the distance between the two pupils of the eye. The second technique is we use an auto-mixed elastometer and we apply it to the transfer fork. Then we position the Nasian relator here and we tighten them when we take the relationship. Now for the third step is the centric relation record, which provides the orientation of the mandibular and maxilla teeth in the central relationship, where it is defined as the maxilla-mandibular relationship in which the condyles articulate deepest in their respective discs of the articular eminence. Here we see where the condyle is in its deepest position in according to the articular eminence. An important note that the central relationship record should never be perforated. Now we will see how we take the central relationship. We do what's called the jaw manipulation, where the dentist manipulate the patient's mandible, where the condyle should remain in the same place throughout the opening closing arch, where the dentition uses a single-handed to open and close the mouth of the patient, or can use both fingers and putting the other fingers under the mandibular border. It is important to note that we should not force the mandible backward, which will lead to a downward translation of the condyles, and the restoration made in such position are in supra occlusion at the elevation stage. So, what we do is, since this relationship is reproducible and it is considered constant, so we repeat it several times until we get the relationship on the whole arch. So what we do first is we take a sheet of soft aloe-wax, and it is adapted to the maxillary arch. Then a piece of hard pink wax is added to the lower anterior portion of the wafer. Some soft metal is folded around the posterior border and blotted to the wafer with a sticky wax to increase the rigidity. We now guide the mandible to the central relationship to take the maxillary and indentations, where we see the cusps tips only. Then we do an additional aloe-wax that is added to the lower incisor indentations, and the record is repositioned, and we repeat the central relation closure. After that, we add an aloe-wax on the area of the first molars. Then we repeat the same thing, where we take what is called a clear indentations of the molar. Any double indentation indicates inaccuracy, so take attention to this. Then we repeat the procedure with adding aloe-wax to the premolar region, and the central relation record is complete. Another way is using what is called the harping base plate wax, and we softened it and fold it into a double layer. Then we trim it to the appropriate shape, and these are the indentation of the place of the canine. When we take the relationship, we fold it back to the canine to direct its position, and we see the final result where there is the shallow indentation, which allows the accurate setting of the cast. In the case where we have insufficient teeth to provide the bilateral stability, we use an acrylic resin record bases, like this case. Here we use an acrylic basis, and we add the wax on it. After we finish this step, we now mount the maxillary cast on the articulator. The incisal pin is removed. This is first. Then the condylar inclination is adjusted to the face bow setting, which we recorded previously. The side shift is set to 0. We do not have any movements in this first mounting. Then a mounting plate is attached. The face bow earpieces are attached to the condylar elements. Here, these are. After that, we must mount the mandibular cast in accordance to the central relation that we got. So we position it on the inverted maxillary cast, and the incisal guide pin is adjusted, and the mandibular cast is oriented in the record. The cast is attached with the mounting stone, here in D. When the pin is raised, the casts contact in the central relation closure. We adjust the incisal guide pin to get a stabilized cast, and the plaster is applied to the pre-wetted cast, and the mounting is complete. Now we will talk how we can use the virtual articulation. Currently, the digital scans can be mounted in either the maximal intercuspation or the central occlusion. To do so, we use what is called a leaf gouge. This is the leaf gouge. It is used to manipulate the muscles of mastication to bring the nerve muscle tension and be able to move the mandible to the central relationship in an easy way. So here we use it to find the central relationship at the vertical dimension when we are going to restore the case. The leaf gouge should not be scanned during the occlusion scan. After the applicable interarch scan has been captured, a digital mandibular movement video can be created. Here we can see the red marks that highlight the centric occlusion during the digital video. Now, with the advancement of the CBCT and 3D printing technology, we can do a replica of the condylar fossa and the actual condyles at the correct intercondylar distance. The maxilla is printed with the correct spatial relationship to the condylar complexes, and those printed structures are then pre-mounted onto a modified articulator frame. Here we can see the CBCT of the skull, and taking the axis of the condyle with the maxilla, printing the cast. Here we can see the full anatomic landmarks that are exactly related to the articulator as they are in reality. This is called the true anatomic relationship of the condyles, fossa and the maxilla, where the articulator upper member is aligned to the Frankfurt horizontal plane. This new method represents the first truly fully adjustable articulator that is more precise than the tracing method that we previously talked about. It saves time and effort, and it eliminates the use or the need for a face bow transform. It is useful in accurate fabrication of complex prosthodontics treatments. Here we can see the centric relationship of the condylar position, and here it in its protrusive inclination based on patient anatomy. Then we assemble the mandible in accordance to the maxilla, where we take the central relationship in the previous using traditional centric relationship record. We have seen that we should examine the surrounding structures of the tooth, which are the muscles and the temporomandibular joint. Then we have seen how the relationship between the maxilla and the mandible is recorded and it is transferred, and then how the advancement of the CBCT and the digital scanning and the 3D printing has made this procedure more accurate and more realistic. We have seen that there is many types, two types of the face bow and two types of articulators, and we see the indications of each of them. We see the methods of recording the central relationship and how we transfer this to the articulator, and how we mount the mandible in accordance to the maxilla. This is it for today. Thanks.